Now we move on to an important talk, that is the assessment of children with CVI. CVI assessment is required not only to diagnose, but also to plan the necessary intervention activities. So let's move on to Dr. Geetha's talk. She doesn't need any introduction. She's the pioneer of CVI in Kerala, and she's attached to the government, District Hospital Palakkad. Over to you, madam.
First of all, let me express my sincere gratitude to the pioneers in CVI, Dr. Gordon Dutton and Dr. Leah Hivernan, for the inspiration and guidance in our CVI activities. The CVI workup, there are 6 components for that. First of all, we have to diagnose CVI, because all children who come to the CVI clinic may not be diagnosed or referred. So, first thing is diagnosis. Then like half of the CVI which present in our clinics, they may coexist with ocular pathologies like squint, ptosis or refractive errors, etc. So those should be diagnosed and treated. Whichever ocular pathologies which can be corrected should be corrected. Then do a proper dynamic retinoscopy to rule out accommodation lag. Then do cycloplegic refraction to correct refractive errors. Then come the functional vision evaluation and do a proper counseling. A word about counseling. These parents must have tired by hearing like this eye is normal, brain is abnormal, like that. They will be doing doctor shopping. But you have to tell them that how their child is seeing. For example, the lower field effect. You should tell them that the child is not able to see the floor. So that they can arrange suitable environment for the child to use the vision. And for habilitation, the proper habilitation can be done by explaining the vision to the parents. And always tell them that they are the persons doing the therapy, and we are always there to support them. This will make the compliance better. And tell them about neuroplasticity to improve the early intervention. So that is about counseling. Then how to diagnose? The CVI, like normally eye is normal, and the ocular findings may not explain the visual difficulties. But mind you, I have already told you that CVI can coexist with ocular pathologies. That is different. Visual behavior may vary. The dictum is that they may vary depending on the child factors like fatigue or stress of the child, loss of interest. Then environmental factors like clutter, visual or auditory clutter. Then history of traumatic perinatal period may be there. Latency will be prolonged. Then visual attention span may be short. And difficulty with the crowded information and associated motor and sensory cognitive difficulties. Cerebral imaging is MRI may show periventricular leukomalacia, but a normal MRI may not rule out CVI. And all children, CVI is a clinical diagnosis, so all children we need not go for MRI. And neurosonography, cystic changes of leukomalacia may be seen. It is predictive of CVI. VEP can indicate visual acuity, and it is used to differentiate CVI from delayed visual maturation, which is a differential diagnosis. Transdisciplinary assessment is needed. This is the classification by Dr. Gordon Dutton. That is children with profound visual impairment due to CVI. Children with, number 2 is children with CVI who have functionally useful vision and cognitive challenges. Third one is children with CVI who have functionally useful vision and who work at or near the expected academic level for their age group. That is called high functioning CVI. Now coming to the evaluation. It should be done in a special clinic, not in our busy OPD, because the visual clutter may affect the child's vision. Child should be well fed, had good sleep and comfortable. And sometimes neck control may not be there, so we can examine the child in supine. Then in CVI with a profound CVI, sometimes sensory tent may be used. To prevent any omission, we use a Dutton's inventory, that which is we have translated to Malayalam. There are two types of inventories. One is for children less than 6/60 vision, and the other one is more than 6/60. I'm not going into the detail about it because we have some 48 questions in that. The dynamic retinoscopy is used to evaluate the ability to accommodate. Show an object at distance and note the retinoscopy reflex. Bring it close to the child and again note the reflex. If it changes from with to against, child can accommodate. If there is no change, that means there is accommodation lag, which can be corrected by +3 glasses. This child was some 6-month-old child, I think. It's not playing. Okay, the other there is no eye contact, and with the correction, the child is seeing. And this child, we saw got this child from a blind school. He is residing in a blind school. Parents thought he's blind. He is having blindism. See, he's having a stereotypical that repetitive movements. So when we asked the child to come to CVI clinic and assessed, and there was accommodation lag, and we gave bifocals. There was some astigmatism also. So now he is doing his routine. And this was a spastic diplegic child who was brought to our clinic for some certificate, not for assessment. And when we did cycloplegic refraction, her eye power, the power was -8. Okay, this and fundus examination is very, very important, because this child was brought by an intelligent mother saying that there is some problem, and there was no eye contact. I thought it was initial days. I was so excited to see a CVA case, and then I saw retinoblastoma, bilateral retinoblastoma. We would have diagnosed it later, but because we initially diagnosed, her vision in one eye was saved because fovea was not affected. So fundus examination is a must. Even the child comes at 3 months. Then functional vision assessment. That is to understand how a person uses vision to perform tasks of daily living in dynamic environment, which is done binocularly. So this is the protocol we follow for function vision assessment. Facial communication distance. You can use the mirror test also to know the visual sphere of communication, or go near the child with a silent smile. Then Liag ratings. This is preferential looking. This is the preferential looking is the principle. See, that is a 6-month-old baby. See how we can see whether the child can see the child's vision. And always explain to the parents the line thickness the child could appreciate compared to that of their fingers. Make them understand. Otherwise, there is no point in doing lots of tests. Always we should tell them. And in CVI, there are some special considerations. Saccadic eye movement may be affected, or sometimes head control may be delayed. Grating may be in the non-seeing part of the visual field, or presence of squint. All can affect this assessment. This is a Leah symbol book for preschool children. And this is for contrast sensitivity. If the child is responding with a social smile, he must have seen the picture of smiling face. See, this is the reduced contrast sensitivity with the same visual acuity. Then visual field. See, this is the field analyzer. The child will smile at this light. And otherwise, in an older child, we can use the leg rise test also. If the child can stand up and visual acuity more than 20/100. We ask the child to stand up and see whether he can appreciate the shoe. And other clues, like whether the child is always clinging on the sari, or whether the child is finding it difficult to climb the stairs, like that. See how she is appreciate that heel, movement of the heel. See. Then hemianopia. This is child with left hemianopia. Then latency will be more, and the span of visual attention will be less. And if there is profound CVI, that child should be assessed in a sensory tent with illuminated toy with auditory and tactile elements added to the stimulus. Light box also will be useful. This is the monochromatic sensory tent. Usually it is in the orange color. And evidence of blind sight should be looked for. Cognitive visual assessments. This is like as Dr. Mallika mentioned, this is the Leah puzzle. See this 12-year-old girl, she is learning LD, and she can't appreciate the shape. And see this Leah mailbox, she is using the tactile clues. And Leah rectangles, all these expression, CVA children may not be able to see the, to recognize the expression. Eye-hand coordination should be checked, and visual closure, that is brain's ability to recognize a familiar word or picture when only a small part is seen. A child usually has somewhere around 1/3 of this 60 atypical visual processing functions. And our aim is to find and know the limits, and staying within them using alternatives, extend the limits. Thank you for patient listening.
Thank you, Dr. Geetha, for very good, very nice illustrative presentation.